Hello, you guys. Today we're going to be discussing DiGeorge syndrome. This PowerPoint will focus on the pathophysiology of DiGeorge, along with genes affected by this condition, the changes of developmental abilities regarding cognitive development and behavioral changes, along with what preventative measures should be taken with individuals with 22q11.2 DS or DiGeorge syndrome. What is DiGeorge syndrome? DiGeorge syndrome is a multi-system disorder that results from at least 50 inadequately produced genes. It affects 1 in 2 to 4,000 live births, and this condition can present itself in a variety of different forms. The most commonly associated medical problems include congenital heart disease, palatal abnormalities, hypocalcemia, genitourinary anomalies, and severe feeding and gastrointestinal differences, along with subtle malformed facial features. As you can see to the left here, especially the upper right hand and lower right hand images, you can see that pulled back chin. This is called mandibular hypoplasia, very common with these individuals. Both males and females are equally affected with DiGeorge syndrome, and mortality in childhood is low, but premature death in adulthood has been more prominent. The pathophysiology of DiGeorge syndrome consists of microdeletions of 1.5 to 3 million base pairs on one of the most complex regions in the genome, and this is known as chromosome 22. These microdeletions are 10 times more common than the next most common human deletion syndrome, and there are 4 blocks located in this region of chromosome 22. Each block is comprised of low copy repeats or LCRs. These blocks LCR A through D define where the breakpoint occurred and are used to describe the size of the deletion. The deletion occurs when there is unequal meiotic exchange along with a lower recurrence of cells engaging in asynchronous replication. These images here show the specific area of the missing genetic material. The image to the left shows those blocks LCR A through D, that tiny little region there, which is that commonly deleted region. Prenatal clues that would suggest further studies include congenital heart disease, polyhydramnios, cleft palate or lip, polydactyly, clubfoot, renal anomalies, diaphragmatic hernia, spina bifida, and craniosynostosis. Dysmorphic features on these individuals most commonly include hooded eyelids, auricular anomalies, in particular thick overfolded ears, attached lobes, cupped ears, and an undeveloped pinna, which you can see on most of these images here. They have those overfolded helices on the tops of their ears. A prominent nasal root or bulbous nasal tip is also a dysmorphic feature, along with a small mouth. Mandibular hypoplasia, which I showed in the previous slide. Now, in conjunction to these different features, individuals will also display changing behavioral and psychiatric and developmental phenotypes. Learning disabilities and abnormal behavior are more apparent from preschool age and on, and these issues should be addressed as early as possible. Those with intellectual disabilities have known to engage in more problematic behavior. They have shown to have more social interaction problems such as ADHD or attention deficit disorder with hyperactivity, autism spectrum disorders, and anxiety. The level of intelligence of those with DiGeorge syndrome has an average mean in the mid-70s. About 55% of these individuals have a borderline to normal intelligence, and about 45% have a mild to moderate intellectual disability. This group additionally showcases a lack of verbal comprehension and reasoning abilities. The wide range of intelligence of those with DiGeorge has been associated with many factors, such as origin of deletion of chromosome 22q11.2, genetic variation within 22q11.2, socioeconomic status, and parental and siblings' IQ. A negative correlation between age and IQ scores have also been noted. So, cognitive development usually shows a decline as the individual grows into adulthood. And now, this decline in cognitive abilities has also been linked with the first symptom of schizophrenic disorders in these individuals. Diagnosis of DiGeorge syndrome. Now, being a submicroscopic deletion, 22q11.2DS is identified using a few different methods. Many patients are being identified with the use of non-invasive prenatal testing via ultrasound or echocardiography. Other studies used include the FISH analysis, and this is a study that is performed with two probes, a chromosome 22 specific probe and a second probe that hybridizes to the deletion region. The diagnosis is formed if a second probe is absent of the tagged chromosome. Now, this particular method will find breakpoints along the developmental gene TBX1 or T-box transcription factor 1, and this is located between LCR-A through B. Breakpoints in this region are typically known to be responsible for congenital heart defects. Now, those with deletions between LCR-B through D and C through D do not include this gene and would be missed using the FISH study, which is why there are other techniques that are preferred, and these techniques include the MLPA, which is used to detect the relative copy number changes of DNA sequence, and it requires a small portion of DNA. It works by quantifying probes that are added to the genomic DNA samples and then amplified in a multiplex manner. Another study performed is called SNP, and this method hybridizes a segment of single-stranded DNA, and each probe is designed to bind to a target DNA substance. It's used to detect imbalances and loss of heterozygosity and copy number changes. Now, in adolescence and adulthood, the diagnosis can be missed, especially because adolescents, adults, and non-Caucasians will display much more subtle facial malformities. As I mentioned above, TBX1 is one of the most common areas that this microdeletion is associated with. TBX1 is an essential gene during development. This gene interacts with several signaling pathways, and it is expressed in the pharyngeal mesenchyme and endodermal pouch. These pharyngeal pouches give rise to the face and upper thorax and are temporary structures. The third pouch gives rise to the parathyroid glands and the thymus. Haplosufficiency for TBX1 would lead to smaller precursor structures and impaired pharyngeal artery development. These compromised arch development subsequently leads to underdevelopments of facial features, the parathyroid, and the thymus. Another important role of TBX1 is in the development of the secondary heart field. This structure is derived from the pharyngeal mesoderm, and it gives rise to the cardiac outflow tract, the right ventricle, and the mesenchyme of the brain. Deficiency in TBX1 can also cause skeletal defects along with an underdevelopment of the brain mesoderm, and this can account for the neuropsychiatric findings. This image here shows the cascade of transcription factors regulating the thymus and parathyroid development. The thymus and parathyroid are the most common underdeveloped regions in these individuals. These ovals here from left to right are the transcription factor interactions required for thymic and parathyroid development. And then TBX1 regulates the expression of several growth factors, which are shown to the right of the brackets. Treatment for those with DiGeorge may require pharmacological and non-pharmacological treatments for behavioral problems such as ADHD, anxiety, and schizophrenia, and any other mood disorders. Prophylactic treatments may be used in conjunction, as these treatments may lead to an increased risk of seizures and movement disorders. Cardiac heart defects should be treated with medicine or surgery as needed. Management of immune deficiency can range from a thymus transplant to no intervention at all. Live viral vaccines may also be administered, and T cell counts should be reassessed when the individual turns about 1 year of age. Palatal disorders would be addressed as for any other child with a cleft lip or palate. This would help improve speech production and communication. And it is important to note that the effect of a treatment for one condition may positively or negatively affect or impact another condition. So close monitoring is always needed when administering medications. The prognosis for those with DiGeorge, it varies widely. It depends on the severity of the condition and the degree of involvement of the organs. Educational plans need to be reassessed consistently, and they should be changed as the person grows. They should be altered as the person ages. Future studies for DiGeorge. So current DGS treatments aim to manage the symptoms, but they do not address the underlying cause. Future studies are hoping to utilize current knowledge of the genetic and molecular mechanisms of DGS to develop more effective therapies, such as gene therapies that would address, again, not only the symptoms, but their underlying causes. Um, in conclusion, it is very important to pay attention to the multi-system nature of DiGeorge syndrome. Early and proper diagnosis of this condition is only going to benefit the individual and improve the general outcome. It is important that early intervention methods be introduced. If these methods are introduced early, then focus and attention can be placed on those specific areas that the individual may be lacking in. And in order to provide these best intervention methods, it's crucial to the individual that there be a team of professionals that can provide their expertise in areas of concern, and they should be able to alter their services as the individual progresses through life. Every individual is different, so the approach will vary person to person. A typical group of specialists or professionals that would aid these individuals would be it can range from immunologists to geneticists to ENT specialists, endocrinologists, cardiologists, educators, psychologists, and psychiatrists. By providing extensive attention in each area of concern, we can truly allow these individuals the absolute best quality of life.